نبتدي our last session in our conference, our congress. يسعدني ان انا اقدم الدكتور بروفيسور نور الدين. نور حد من ابناء القصر العيني وهو كونسلتنت في المانيا، والدومين بتاعه هو الانترفنشن راديولوجي. ان شاء الله يمتعنا بالمحاضره الاولانيه على الترانس جاجولار انترا هيباتيك بورتو سيستميك شانتنج اللي هي تيبس سبيكترم اوف كيسز. اتفضل يا دكتور نور.
بسم الله الرحمن الرحيم. شكرا جزيلا دكتور عمرو. دكتور عمرو ده أستاذي وهو اللي كان مشرف عليا في رسالة الماجستير، ويعني اتعلمت منه يعني ومن أساتذتي طبعا كل يعني الخلق قبل العلم يعني. فأنا أشكرك شكرا جزيلا، ويشرفني إن أنا أكون متواجد معاكم في مؤتمر الاسم النهارده. Transjugular intrahepatic portosystemic shunt spectrum of cases. The pathophysiology of portal hypertension, as you know, that the liver cirrhosis is one of the most important factor for the portal hypertension due to cirrhotic changes and fibrotic changes that compresses the venules of the portal tracts, leading to elevation of the portal pressure above 25 millimeter mercury, which is defined as portal hypertension. The consequences of portal hypertension, the dilatation of the portosystemic collaterals leading to the development of varices, which are either esophageal varices or rectal varices, as well as you can see a massive ascites due to excessive hydrostatic pressure, which leads to oozing inside the peritoneal cavity. The aim of TIPS is to decompress the portal pressure by creating a shunt between the portal circulation, which carries the higher pressure, towards the inferior vena cava with low circulation pressure. This will reduce the incidence of variceal rupture as well as relieves of the ascites. This is a minimal invasive technique in comparison to surgery and other procedures. This is a movie that shows the technique of TIPS in a simplified manner. Using a Seldinger technique and under ultrasound guidance, we do a puncture of the internal jugular vein at the right side to go in continuity in line through the superior vena cava, the right atrium, and to cannulate the hepatic veins. The most important veins that to be as our target is the right hepatic vein. And sometimes, due to technical difficulty, we go for the middle. But the worst results are when we puncture the left hepatic vein. After that, we can go through by specific TIPS needle to puncture the liver parenchyma. Afterwards, we cannulate the portal vein through the catheter and guide wire system, and afterwards dilatation of the tract using a balloon up to 8 millimeter is the preferred dilatation, and then we apply the stent graft. This is the high recommended to be a covered system in order to isolate the tract created from the minor biliary radicals or small vascular channels. This is a case which has a severe ascites. You can see in the axial images as well as in the coronal images, the liver is shrunken, is huge splenomegaly, and you can see the marked dilatation of the portal vein and the umbilical veins. And we go through transjugular access and we puncture here the bifurcation of the portal vein. You can see largely dilated umbilical vein, and afterwards we go with the catheter inside the main portal and we measure the pressure, and here the pressure was around 26 millimeter mercury. Dilatation of the tract followed by application of the stent. We do dilatation with 8 millimeter balloon. And afterwards, you can see that the pressure is deviated and the pressure is becomes reduced, and this will improve the symptoms. So the established indications for the TIPS are markedly dilated varices or recurrent bleeding varices, as well as excessive refractory ascites to medical treatment or recurrent paracentesis, as well as hydrothorax. And the most, also one of the most important indications is the Budd-Chiari syndrome. What are the contraindications for TIPS? Acute liver cell failure due to the increased incidence for the hepatic encephalopathy due to increased level of ammonia in the blood, sepsis, and isolated gastric varices or splenic venous occlusion, because the portal venous system has no effect on this. And I will tell you what are the proper treatment for this reason. Heart failure or pulmonary hypertension, because this shunt will increase the flow and the cardiac workout. Severe uncontrolled encephalopathy, because TIPS will shift the blood directly with increased ammonia into the circulation. Relative contraindications is the cavernous transformation due to its technical difficulty, and there are many publications that are with, and many other publications in the literature are against insertion of the TIPS, biliary dilatation, or abnormal coagulopathy. For isolated gastric varices, we go for a technique called balloon-occluded retrograde transvenous obliteration, because there is no impact of the increased pressure on the treatment of isolated varices. The evaluation of the cases by two systems, either the Mills score and low risk factors by Mills score up to 12, while the moderate risk factors between 13 and 17, and high risk for Mills score above 18. And the Mills score depends on the values of the creatinine, bilirubin, as well as the INR. The child score system, the best outcome is for patients with child A and less in child B, but it is obsolete to do for child C because the outcome is very limited. Before going to TIPS insertion, you have to study the CT scan. We do triphasic CT scan, and we look for the patency and the anatomical relationship between the hepatic veins as well as the portal vein, to see if there is dilated biliary duct system, and to show if there is varices in order to do obliteration and embolization of the tips of the varices, ascites, and cysts or masses, as to exclude HCC in the track of your puncture. This increases the risk of pulmonary metastasis by puncturing HCC lesion. This is the CT scan. You have to look for the anatomy, and you have to exclude the presence of any mass lesion at the liver, or to be oriented how to go and which vein is suitable to choose. The sets for TIPS, we have Optimid set. This is the system that we use in our institute, but other systems like Coxet, and for extremely important to use a covered stent graft. I know because of financial issues, venous stents are mostly used here in our country. However, it has higher risk of complications as well as increased risk of malfunction and occlusion. This is a case of severe ascites and recurrent bleeding from varices. We decided to go for TIPS, and you can see here, this is the puncture. I'm inside the portal, and afterwards, after cannulation of the portal system, you can see a huge varices. Immediately post-puncturing and after insertion of the wire and the catheter, we go for dilatation of the tract using 8 mm balloon. And you can see this is before insertion of the TIPS, markedly dilated portal vein and umbilical vein. And after insertion of the TIPS, you can see that the umbilical vein markedly collapsed, as well as the varices. But it's highly recommended that when you are doing the TIPS is to occlude the varices, because it's a position for shunt, and this decreases the risk for hepatic encephalopathy, as well as improves the flow inside the stent and leading to its improved patency. I go for coiling such varices, and this improves the outcome and control. This is here the coils, and you can see post-coiling that the varices are occluded and the risk of bleeding is decreased. One of the rare cases that you may face in your practice is the presence of such a huge aneurysm. You can see this aneurysm extrahepatic. This is a part of the right portal, which leads to aneurysmal formation, extrahepatic and paraspinal. You can see this in the coronal image here in CT. This is a large aneurysm, extrahepatic due to portal hypertension. You can see in this before insertion of TIPS that the aneurysm is at due to the shift of blood inside this aneurysm carries high risk of bleeding, and post insertion of TIPS the flow is shifted away from the aneurysm, so it was the outcome was really good. And after follow-up, you can see in this MRI the thrombus formation inside this aneurysm due to shift of the blood away from its track. Case number 4. This is a case of persisting bleeding from duodenal varices. This is one of the cases that we see also in our practice, and most of the gastroenterologists, they go for bandage ligation of these aneurysm. This is an emergency case. I remember the patient was bleeding at 4 o'clock in Sunday morning, and the gastroenterologist couldn't be able to occlude the bleeding source from these varices, and also the surgeon refused to do such a Whipple operation at Sunday morning in such a case, because the treatment of choice is duodenectomy. So they called me in the on-call, and the decision was to do the TIPS. I punctured here the portal vein, and you can see the not markedly dilated due to shift of the blood inside the varices. And after insertion of the TIPS, you can see here that the varices collapsed and the bleeding was stilled. The bleeding source was occluded due to relief of the pressure and shift of the blood from the duodenal varices. Budd-Chiari syndrome, our colleagues in Ain Shams, they have their own technique which called DIPS, which is direct ultrasound guided puncture of the portal vein, as well as the IVC ultrasound guided to do the insertion of the TIPS due to occlusion of the hepatic veins. But we can do it in another way, is that just cannulation of the stump of the origin of the right hepatic vein is sufficient to puncture the liver and go for cannulation of the portal vein. Due to this, this is called the safe zone of the IVC. The upper 5 centimeters are covered by the liver parenchyma. So if you puncture, the risk of bleeding is very, very low, because the IVC is surrounded by the liver parenchyma, and any risk of bleeding will be occluded, being retroperitoneal. Another technique that may be helpful is the indirect portography. I go with the catheter inside the superior mesenteric artery and make a venous phase, and I will see the portal vein. So the anatomy of the portal vein will be easier to detect and easier to make the puncture. And afterwards, you go through normal TIPS and insert your stent inside the system, and you can go for, you can see the flow from the portal inside the TIPS inside towards the systemic circulation without any obstruction. Case number 5, portal hypertension with partial thrombosis. This is some critical case. You can see that the right portal branch is occluded with cavernous transformation of the right system. So we go through the middle hepatic vein or the left hepatic vein to puncture the left side in order to switch the flow from the portal towards the IVC. This is through the first injection. I go here for wedge portography. This means I inject the contrast inside branches of the portal of the hepatic veins, and through the the contrast goes through the parenchyma and blood will be shifted towards the branches of the portal in order to see. It's a difficult case here, but we could be able to puncture the left branch of the portal vein and afterwards inserted the stent. But you can see here the stent was short, and the upper part of the stent here there is a stenosis. It's proper to show and see properly, and afterwards we extended the stent more towards the cranial aspect in order to create a proper shift and proper flow. What about TIPS dysfunction? TIPS dysfunction due to occlusion by thrombosis. You can see by Doppler, the flow is reduced, and most of the cases due to thrombosis. As you can see here, the stenosis inside the TIPS graft due to thrombus formation. Of course, the treatment of choice is, and you can see that as a complication, the the coronary vein is dilated with varices formation. After cannulation of the system, I get these varices occluded by coils and glue, and afterwards I did the balloon angioplasty of the stent, followed by elongation of the stent to the cranial aspect in order to improve the flow. Another complication is the hepatic encephalopathy. You can see this is a case in which the patient developed hepatic encephalopathy, and in the treatment of choice is to insert a reduction stent. This is a stent 8 millimeters at the periphery, but it has a 4 or 5 millimeters at the center. This will reduce the flow and will result into reduction of the flow and decrease the incidence of the hepatic encephalopathy. You can see that the inserted reduction stent inside the stent graft. The last case I'm going to describe is portal vein recanalization and transjugular antihepatic port systemic shunt. This is one of the difficult cases technically. You can see that the main portal is in cavernous transformation, and the access for treatment in such a case is to go either transsplenic or transhepatic. The proper choice is to go through percutaneous transsplenic and cannulate the splenic vein, and afterwards we do the TIPS. But it needs some tricks. This is here the catheter getting transjugular. I made a wedge portography. You can see here the convolute of the cavernous transformation of the portal vein. So ultrasound guidance, puncture of the splenic vein, and this is followed by insertion of our sheath and catheter. You can see this is the splenic superior mesenteric vein, and this is part of the splenic vein and superior mesenteric, and here the confluence of the portal occluded. Just we inject contrast. We try to cannulate this part. This part is the residual lumen of the portal vein. It's a fine line getting at the confluence and goes through superior and lateral through the right lobe. And this, I go for negotiating this part of the residual part of the portal vein, insert the guide wire. Afterwards, I'm here inside the true lumen, but there are multiple collaterals due to cavernous transformation. To get cannulation, we insert here a snare inside the catheter and try to puncture transjugular this part of the snare, the ring of the snare, like this way. I puncture the snare, I put the wire inside, and afterwards I withdraw the wire through the snare like this way, and here I'm creating a channel, or the guide wire is running between the hepatic vein, the liver parenchyma, the portal, and through the splenic vein. Afterwards, simply go for dilatation and put the stent, and this is the final result. You can see that the reconstructed portal vein and restoration of the flow. So in conclusion, TIPS is an effective minimally invasive technique for treatment of persistent bleeding varices and refractory ascites due to liver cirrhosis and portal hypertension. The outcome is dependent on the adequate patient selection, and multidisciplinary liver board is required for individualized decision and management. Finally, Accept my best regards.
We'll keep the questions to the end of the session. Now it's